as you know, rare diseases, patient communities are small. And unless we're working together, we can't get anything done. I'm going to talk to you a little bit about where we are now in Canada with regard to rare diseases. And I will say, like with acromegaly, you and I, God, we worked together on a submission, back in 2006, I think it was. It's been a long time. It's been a long, long journey together. And I think what we see today, I think we have to agree, is so much different than what we saw back then. It's not there yet, but we are such a long way. And it really are only there because we've worked together as the rare disease community, right? Each one of us alone, we're not going to get very far. I think some of you know I have 2 children, both who were born with different rare conditions. And I'm really fortunate because, both my kids now are adults. They're doing amazingly well. I was saying to somebody before, I have 2 grandchildren who are just, the most amazing creatures that we've got. So, but again, with each of these conditions, the only way we can make advances is by working together. I'm going to talk to you a little bit about where I just came from, because I was just in New York. We had a week-long set of conferences there, but we ended it up with Thursday. It was actually our second official side event to the United Nations high-level meeting on universal health coverage. And for us, it's been really important because what we wanted to do was to make sure that rare diseases were identified as, in fact, an important subpopulation, a neglected population within universal health coverage. And 4 years ago, we fought really hard to get the mention there. Recognizing that it doesn't solve anything, but it gives you the opportunity to push your governments. 192 countries signed on to say, yes, we recognize universal health coverage, and yes, we agree that rare diseases must be included in any form of universal health coverage. Doesn't mean anything's going to automatically happen, but what it does allow is for patients, healthcare providers, and others to actually push then to say, here's what we need. Here's what it is that we need you to support. I may just jump to the good news actually, because as you all know, Canada has finally acknowledged rare diseases. 2019, we got the Canadian government made a commitment of $1 billion to bring in a Canadian rare disease drug strategy. And I'll talk a little bit about what's happened since then. As you all know, a commitment in terms of funding does not necessarily mean that everything is going to flow up directly from it, but a lot of things happen, right, with that. So I'm going to talk a little bit about where we are now. I am going to focus a lot on drugs, but I really have to say I so much appreciated your presentation in terms of the surgery. And in some respects, with acromegaly, you're so lucky, right? Because first-line treatment is surgery. And first-line treatment can absolutely do so much. And I love what you said as well, is that even though we don't get it all, it actually reduces the need for other treatments. And it really makes a difference. And you guys are doing better and better at it. So at some point, you'll get it right. And then we don't have to worry about that aspect. So keep working at it. It'll happen sometime. But it is true, right? And that's actually fortunate, because there are many other conditions, many other rare diseases that don't have that option or don't have that kind of success. And I think that's really important. I didn't know it was 25% that don't get that complete, kind of recovery, which is pretty damn amazing. And also pretty damn amazing is that you do have some of the best surgeons in the world right here in Canada. And you do have access to the treatments right here in Canada in terms of surgery. You don't have a guarantee in terms of drug treatments, but you do have a right to ask for the right kinds of other healthcare services and surgical interventions. And I think that makes also a difference in terms of attracting the best clinicians and also attracting the research. The research study that's taking place now, this is something that is not necessarily given, and you know that very well, Deanna, in terms of what happens with the world, your World Alliance. This is amazing. What's important for us is also, as the advances are made in each rare disease, it helps us to improve what we can do for all rare diseases. That's the nice thing about rare diseases, right? Is that none of these sit in isolation. What we learn and what we advance for one helps all. But that means then again that we need to make those connections across the rare disease community The other thing, of course, is the very important thing for rare diseases, more than almost any others, is the international alliances. Because we know that we don't learn enough and we don't get enough just by working within Canada. Your healthcare professionals, the same as the patient organization. We learn so much by doing the international, which is why I think as Nana was going through all this, I do serve as chair for Rare Disease International, which is our global alliance of rare disease organizations. I also serve, actually by default, as the president of the Asia Pacific Alliance for Rare Disease Organizations, not by total default, because I really obviously have a lot of affinity for advancing rare diseases. But what we also know is that we're quite fortunate in Canada where we sit. When we talk about universal health coverage, we actually have universal health coverage in Canada. Not for everything, but we have pretty high. Not only do we have it, we have really high standard of universal health coverage. Certainly better than, I think as you alluded to, even our neighbors to the south. So really great care for a certain echelon, but not necessarily great care for everybody. And I think that's, again, where we're really fortunate. And when we look across the world, even in Europe, there's only a handful of countries that actually do as well or better than we do. I mean, when we think about standards of care, I would say some of the other countries that, really do make the mark are also ones that we should be learning from. So let me talk to you about where we are now in terms of our rare disease strategy in Canada, what's working, what's not working, and what we need you folks to do with us to help move it forward. So I should be able to figure this out. So this is CORD. CORD is a network of 100+ patient groups. Our mission, obviously, is to work with everybody together in terms of all those affected by rare diseases. And I'm going to start talking a little bit about the drugs because, as I said, Dan and I go way back in terms of trying to get access to drugs for acromegaly. We had some wins and we had some losses there. So part of the challenge in Canada, as I said, even though we have universal health coverage and even though everybody has a right to have access to health care, guess what? You do not have a right to have access to drugs. We're one of the only countries in the world that has universal health coverage in which drug coverage is not included. Did you know that? And when people say to me, well, we can sue the government, we can make a demand for access to drugs, I say you do not have that right. It is not included anywhere. We do have public drug plans that are provincially led, but that's not a right. It is a provision that's put in there to help make up for the fact that there are lots of people who do not have private drug coverage and need to have access to drugs, but it is not the same as actually have it included in the Canada Health Act. Drugs are not included in the Canada Health Act. You do not have a right to drugs. You have a right to primary care, you have a right to surgery, you have a right to many other provisions. You do not have a right to drugs. So this is a really big hole in which we have here. In the U.S., you don't have a right to anything, so it's fine. but being better than the U.S. in healthcare is nothing to brag about. But anyway, but that makes it, though, very challenging when we talk about new drugs that are coming in. And it makes it really challenging when we're talking about rare disease drugs. And as you heard already, and as many of you know, many of these drugs really are now just becoming such amazing therapies. Most cases, obviously in acromegaly, most of it's adjuvant therapy, right? I don't think we've got it. I don't think very few people here, right? Those who are not indicated for surgery would see drug therapy as their first line therapy, and quite frankly, would still not work as well as if you could have the surgery. In terms of you can shrink the tumors, but obviously better if you can remove the tumors. So, but it is important if in fact you don't, or if you don't aren't able to totally remove the tumor. So this is really important. But the challenge is that you do not have that guarantee. The problem in terms of drug access in Canada then is that we do have a two-tier system. We have private drug coverage, and many people are in fact covered, 75% of people are covered. But the other percentage are not, and especially as you get older, right, and you don't necessarily have the same kind of private coverage that you have. But also for rare diseases, many of the patients who rely on drugs have to get it through the public plan because they're expensive. Your private plan would not necessarily cover it even if you did. We have patients say, I can get the drug, but it means nobody else in my family gets covered. I can get the drug, but I will top out my plan, but in 10 years, and then what? So this is the challenge we've got in terms of the adequacy of the drug plans. The other challenge we've got, of course, is that, again, because drugs are not guaranteed in Canada, is that they're slow to get onto a public formulary. And this is why we go through the kinds of machinations we do. This is actually, the challenge is that what you can get in the U.S. is rapid access. A drug gets approved by the FDA, you have a private drug plan, you got it tomorrow. A drug gets approved in Canada, used to be if you had a private drug plan, you get it tomorrow. Now what's happened is that many of those private drug plans said, let's wait and see what the public drug plans do, especially if the drug is new and it's expensive. So this is a big challenge. And in the public drug plans, again, it's not a guarantee, it's an add-on for many of these, and they see it as their drug budget. It's a very long, slow process. And the process really, was designed in the early days when the drugs were not necessarily that expensive, when the drugs were not necessarily big blockbusters, even before the biologics came out. And what you see here is that we go through many steps to actually get a drug onto a public drug plan. It starts with, obviously, the Health Canada approvals, and I will say Health Canada, starting in about 2012, 2014, 15, really began to pull up its socks. It really began to be able to make approvals. Because the other challenge with rare disease drugs, and you will know that, is that small patient populations, small clinical trials, oftentimes short clinical trials, because there's no other therapies. You want to get the drugs approved as quickly as possible, especially if it's a progressive condition, and you want to be able to come in as quickly as possible to be able to halt the progression. In many cases, compared to drugs that are for large cardiovascular diseases, for arthritis, for other diseases where you've got thousands of patients, and you actually know over a long period of time how well these drugs work. For many of the rare diseases, we're kind of bringing them in, but we're not exactly sure how well they work. And a lot of times the drugs that we're getting for some of the rare diseases are drugs that are approved for another condition, so we think it's going to work well here. But guess what? Thinking it's going to work well here and showing it works well in a small patient population does not necessarily convince the public payer that, okay, we should fund that drug. So it's a big challenge for us. It goes through a stage where it has to be approved in terms of pricing. It goes through a stage where it has to be approved for something they call cost effectiveness. And cost effectiveness is actually a death pit for rare disease drugs, because basically it asks the question, how much value do I get for this drug, and how much is it going to cost? And it's a formula that looks at how much does it improve your condition, but most importantly, how long does it improve your life? And then how much does it cost in order to improve your life? People sometimes say to me, what's the value of a life? And I can tell you exactly what the government thinks your value is, because there's a number. Guess what? There's an actual number. And it says if it costs more than that number to give you an added year of life, then you're not going to get it. If it costs less than that number, we can at least consider it. So there's an actual number. The problem is that number's the same number regardless of whether you have a rare disease or whether you have a very common disease. Whether you're talking about an innovative therapy that is brand new for this space, or whether you're talking about a therapy that's a second or third generation improvement on an existing therapy. Change in the price there might be very small. Change in price here is going to be huge, and in some cases it's going to be really huge because there's nothing to compare it to. If the question is, I've got a new therapy that costs $100,000, $10,000, whatever it is, and the comparison to it is zero, guess what? It's so much cheaper to do zero. And that's the challenge we have, is that the way in which we assess these drugs really is not different for rare diseases and for innovative therapies and even breakthrough therapies than it is for ordinary, more common conditions that already have a lot of therapies around. So this is a challenge. Goes through the processes to get the assessment. You remember the first one we had was a no. It was pretty clear. We don't see that the evidence is there. We don't actually believe that it actually provides the kind of improvement in shrinking the tumors the way we think. And just shrinking the tumors, it says, we don't necessarily believe that that's actually going to affect the disease. Like, duh. I mean, the tumor is what causes the disease, so it shrinks the tumor. How can you not get? But they said we don't have any evidence that by shrinking those tumors, it actually over 10 years is going to improve. Well, yeah, okay, the drug's only been around for like 2 or 3 years. Like, you have to think and extrapolate a little bit. And the question is, we don't have the evidence. In cancer, it took them years, actually, to be able to convince the payer. So it's not just us to say, okay, shrinking a cancer tumor actually demonstrates that the tumor is actually not going to be causing the kind of illness. So, progression-free survival is actually a given now in cancer. If your tumor doesn't continue, we believe that you're actually going to live longer. It's taking a long time in other diseases to make that same case. So I think these are some of the challenges we have in rare diseases. We don't have 10 years of evidence in terms of changing a condition. So this has been a challenge. And the sad part, I think, as I said, in many of the cases, the private drug plans are also now kind of going through that same step. So this has been our challenge, is how do we get access to drugs? One of the challenges in that, and you can talk to some of your drug representatives that are here, is that they don't bring the drugs to Canada in. They say, look, it takes a long time to get a drug approved in Canada. Takes, your drug plans don't want to pay for the drug, so it takes another long time to do it. And if they do, they only want to pay for a small number of populations. Why should we bring a clinical trial to Canada when you're not going to actually reimburse this drug, right? And the clinical trials are so important because that is what gives us the opportunity to have our clinicians have experience with these therapies, for us to actually get patients who actually may need it as soon as possible onto these drugs and to be able to demonstrate it works. And oftentimes, now we've done a better job with our assessment bodies to say, used to be they said we need to see Canadian patients who've been on the therapies and see how it works for them. Well, we didn't have any clinical trials, so we don't have any Canadian patients. And so you end up in this terrible circle. Now at least it's okay. Just give us any patients anywhere. So that actually has opened up the ability. I was talking to Deanna, we have a drug for Cushing's that we're trying to get submission on. Well, there are only Cushing's patients in Canada that have gotten drugs because the clinical trials didn't come to Canada. We have some extension drugs, but even those patients have only been on it for a very, very short period of time. We don't even have benefits yet. So we are trying to kind of open up that evidence. But this is the challenge we've got. This is why we are working, and this is not something that's just for acromegaly, right? This is something that's common across the rare diseases. And we can't make the case just to say, okay, if we can talk about it for, the many thousands of patients are affected, it helps us a lot. So what we're trying to do then with this whole, proposal for a rare disease drug strategy is how do we improve access here? How do we actually speed up the access? How do we make it so it's more expansive? How do we make it so that, for us, the most important thing is instead of going through, as we call this long stage elevator here, many stages, taking sometimes up 2 years, sometimes up to 10 years to get a drug that's been approved by Health Canada to actually be reimbursed. Can you imagine what that's like? We often ask the question, what's worse, to have no drug or to have a drug and not be able to get access to it? And that's the case that many people, and to watch the disease progress for yourself or your loved one, knowing that drug is there. So what we want to do is to be able to not only speed it up, but also to make it available to people earlier and to make it available to people even when we don't have full evidence. I mean, this is the challenge, right? A clinical trial says, is the drug safe? Does it work better than a placebo? Is it, on balance, going to provide benefits? The problem is that, of course, you can only do a clinical trial for a period of time, and you can only collect evidence from a certain amount of people. With rare diseases, shorter periods of time, smaller numbers of people, so the evidence is not quite as strong that we can guarantee it's going to work. And this makes it more challenging in terms of getting it reimbursed. What we're proposing is take the evidence that we've got. Health Canada says we're reasonably assured that it's safe. We're reasonably assured that it actually has more benefits than harms. And we're reasonably assured it's going to work for this group of people. We say, oh, fine, take that recommendation, make it available to people. Get your clinicians involved. Monitor people. If they actually show it's beneficial, keep them on the therapy. If it shows it's not beneficial, take them off the therapy. Take what we call evidence in real world evidence in real life. Patients have to consent to it. They have to be willing to continue to participate and to provide their evidence, right? But we are not then stopping people from getting access. Many times the recommendation is we don't have enough evidence, go back and do more clinical trials to get more patients. do 2 or more 3 years of clinical trials. And what we're saying that that's not satisfactory, because it means very small people, it means few people can get access. And quite frankly, most other countries aren't asking for it, so a lot of drug companies say, why should we do more trials when in fact we're getting the drug reimbursed in other countries? So this is a big challenge. So we're working towards it. I'm actually speaking more. So this is the challenge, as we say, in rare diseases. Part of the problem, as I say, is that we only get about 2/3 of the drugs for rare diseases that the rest of the world gets. And it's all the reasons I'm telling you. And sometimes it's drugs can't come to Canada. And I know for our representatives for drug companies here, many of them are fighting inside their own companies to get the drugs to come to Canada. And they're basically saying, well, why should we prioritize you? For all the reasons I just said. And of course, our drug representatives are really fighting hard to try to get it into Canada and try to work with the clinicians and work with the patients and get the advocacy so that we can say, yes, this is a good place to bring in drugs. We're still having that challenge compared to Europe, compared to the US. Part of the problem, as I said, is that we are actually, this whole issue of being delayed, having a long period of time in order to get access. And this is, from the very beginning. And it becomes a vicious circle, right? The poorer our environment for getting approval for drugs, the less Canadian companies can actually make a case with their international, companies that they should be coming to Canada early. This is why this rare disease drug strategy is so important. It's a signal to say, okay, Canada's open for business. We're open to bringing in more drugs, right? We need to get to the point where companies can come to Canada at the same time they're going to the FDA, at the same time they're going to the Europeans. And this is kind of what we're saying as well. I don't want to belabor it. Part of the challenge has been that, okay, rare disease drugs are so expensive. This is a slide that just basically says that's a lie. And I can't say it any more clearly than that. Look at how much we spend on drugs, okay? This is the public health spending on drugs, $256 million there. This is what we spend on rare disease drugs. And when people say, oh my God, that's going to break the bank, that's going to break the budget, like, really? Even if I double that, even if I tripled it, there's no way I'm going to break the bank. This is the allocation we've got in terms of spending. This is what we spend on rare disease drugs compared to what we spend on everything else. This is a minuscule amount. It's still only about 2 or 3% of the total drug spend. I mean, we're not talking, even though some of these drugs are individually expensive because they serve small patient populations, because they're still highly innovative, there's just no, so, anybody says, oh my gosh, these drugs are terribly expensive. Well, yeah, no. Not in the reality of it. As somebody says, it's kind of like a rounding area in the federal budget. Let's not get too excited about it. Part of the problem is that we in Canada have been very slow in having any kind of a rare disease policy. I mean, you can see that, the U.S. in 1983 started it. That's when drugs started to come in. You've got other countries that have come in. There's a whole lot more. And Canada, we finally got something. 2019, the Canadian government says, okay, we're going to bring in a rare disease drug strategy. Mind you, 2019, then we had an election, and we went to an election, and of course 2020, we all had COVID, so nobody wanted to work on this, and finally we at court said, forget it, we'll start consultations ourselves. We kept hammering at them. Everybody says, we're too busy with COVID, we can't talk to you, which probably is true. I mean, I'm not saying COVID wasn't important, and Health Canada and all the others were not really concerned with COVID, but gee whiz, you promised us $1 billion, and it's kind of sitting there somewhere. They said, don't worry about it, it's in the budget. I said, being in the budget does not help getting access to people. I don't want it to be in the budget. I want it to be spent, So it's nice that you've got it in the budget, It's sort of like being a kid, and your parents says, it's okay, we've got it saved away for you. Like, what do you mean saved away? We want to have it now, right? So it's not good, So sometime around Christmas, you can have your gifts. I need it earlier than that. It's not going to work. It's not good. So this is what we've been trying to do. This is a... Exactly. The sad thing is, it's a life-saving carrot. It isn't like, okay, this is kind of a nice thing to have. In some cases, they're life-saving, life-transforming. This is something, I won't belabor it, and I'm probably going to go way over time, so I'm going to go faster on this. These are two slides I've got here are really important. This is research mostly coming out of the U.S. at this point, but also Europe now, and we're doing a study looking at even low and middle income countries. I won't go into details. You can have the slides. You can look at it. It references the study. What it shows is that diagnosing, and you know how difficult it is to diagnose even acromegaly, right? How many misdiagnoses you have and how long it takes to get an accurate diagnosis. I mean, Deanna's coming to a meeting that's happening in Europe. It's coming up. The challenge of diagnosing adults with rare diseases. We think of rare diseases, right, as being newborn screening, a children's disease. Both of my children, of course, were born diagnosed at birth. Well, one of them's diagnosed at birth. The other was never really given a real diagnosis. But we think about them, right? As we talk about adults, it's so much harder to get a diagnosis because, you know, a lot of other things are kind of potential causes for what it is that people may be experiencing. What these studies show is when you collect the information around the cost of diagnosing and even providing treatment to a patient for a rare disease, even an expensive treatment, is less than the cost of not diagnosing and not treating. And this is what we keep saying, is that just because you don't diagnose and you don't treat doesn't mean it doesn't cost anything. And what's important in these studies, it shows obviously it costs the patients and the families a lot, right? Because you're not, number one, if you don't have a diagnosis, you're going over and over back into the healthcare system to try to figure out what's wrong. If you don't have a diagnosis, you're also doing all kinds of other crazy things that you think might be trying to help treat the symptoms that you got, but all of them could be wrong, and some of them are actually bad. And even though treatments may in fact be expensive, treating it, as you can imagine, actually does improve. I mean, that's the whole idea, right? And if they didn't, then you don't keep using them. And what these studies have shown, it is cheaper to diagnose and treat than it is not to diagnose and treat. I mean, we probably sit here and go like, duh. We have to get off, and we say it, right? But this is evidence. This is one of the things we want to start doing in Canada. And the Duchenne Muscular Dystrophy community has done some amazing work collecting what's the cost. Cost to the person, cost to the family, not being able to work, not being able to work part-time, not being able to return to work, also having to care for it, right? Leaving work, having to care for someone with a condition, and the cost of all the wrong treatments. The cost of non-treatments, especially with a progressive condition that actually ends up having tremendous disabilities that you may have been able to kind of address if you treated earlier. And I think acromegaly is probably a really good case study to take a look at. And I think many of you would intuitively know it would have been so much better if we could have diagnosed earlier, we could have gotten the right treatment earlier, and we've been able to monitor it earlier than if we'd let it go. And what it shows in here is not just the cost to the families and the patients, the cost to society, the cost of the system. I mean, if this is not a wake-up call, I don't know what can be. And if you want to talk about how we do things cost effectively, if we don't look at this evidence and say, okay, we need to do this, I don't know what will. So this is what we as a community then need to be coming behind and be able to do, is to push the case. And I'll talk a little bit about, okay, so this is what we're saying. The proposed pathway for us is let's start, get the drug approved by Health Canada, let's start making it available with the right kinds of support from the clinicians, from the patients themselves. The important part we want to have in here is we want to have a patient data platform. If we want to monitor how well a drug is working, we need to actually monitor the patient, right? But who is going to know best in terms of how well your symptoms are being managed with the drug? You are, or the parent is. And what we need to do is make it easier for people to actually be able to track that information. I mean, even your clinician's not going to, right? Because you don't see your clinician every week. You don't even see your clinician every 6 months sometimes. You may not see, and then, so there's no way they can keep track of what is happening to you. So we need to be able to do this. So one of the things we're trying to invest in health for CORD is a patient data platform. We've seen some amazing examples which allow patient input. And guess what? Technology is going to be our friend. And all these high-tech people in here. Because what the new technology is allowing us to do is something we couldn't do before, and that is enter patient information using free language And on a back end, it can translate it into evidence. It can translate it into categories that can become data and accumulate it. So you can imagine if we all entered our information in free form, trying to analyze it would be a nightmare, and it usually is. But if we've got a back end, think about what AI can do, right? If ChatGPT can write a novel, it can do this. And this is what we're doing. We're letting AI kind of take all this and say, okay, what are the commonalities? What are the categories? And what is it across these 500 patients I've got that has been able to become up with consistent information, even though we've all entered in different ways, right? This is great. We're getting to the point where we can actually be able to do some of this. And so this is what we want to be able to do, track it, and then be able to, we oftentimes get the pushback that a managed access doesn't work. If we start a patient, they won't want to come off the therapy. I'm kind of like, are you nuts or what? Who would willingly, especially some of the ones, right? Some of the new therapies now are oral, but some of them are really infusion, they're injection. Who's going to willingly go in and take a medicine or give their kid a medicine if we can show that it doesn't work? It doesn't go that way. Nobody just wants to do it. But we need the evidence, right? We need the evidence to you as a patient, obviously. And if you can see, okay, this is not working. And then we talk about the old things with chemo, right? 2/3 of patients who go in for chemo, right? If that chemo is not right for them, it doesn't work. But if I say to you, it's okay, it's not working for you, really clearly not affecting your tumors, but guess what? You can come in every 3 days. We'll give you the chemo. You'll lose your hair. You'll feel nauseous. You won't be able to work. But, we'll give it to you every week. Who's going to show up for this? I mean, this is like, what kind of fallacy in thinking do people have once they start to apply this? Anyway, this is what we're working towards. The other thing we're working towards, so this was the announcement in March. They announced $1.5 billion. So they upped it to 3 years for a rare disease drug strategy. This is what we've allocated now. They have got $68 million, which they put something around what they're going to do with. Guess what? $1.4 billion is tied up in bilateral agreements. We have no idea what's happening there. We have no idea what they're doing with it. We have no idea they're even having discussions around it. This has become our new problem, is how do we unlock that $1.4 billion that is now tied up in bilateral agreements. And you know how hard it is for provinces and the federal government to come to agreement on these bilateral agreements. We have 2-year-old health agreements that have yet to be signed. I mean, in Ontario, it took them, 2 years to sign the child care, child support program for, this is madness. So this is what we're working on. The good news is, and I won't go through the rest of it. The good news is that we were just at the United Nations, and we had a high-level meeting, a side event at a high-level meeting, and for the first time, we worked really hard on it. We got Canada to be represented. We said, look, you've made the big announcement. You're there on the international stage. Will you not come to our meeting? We had 2 of the queens from Spain and the queen from Sweden that gave opening addresses. We had 8 different health ministries that came in, and we said, can you not come? And actually, at the end of the day, Mark Holland, who's our new health minister, really, I think, did try personally to come. He couldn't come, but they did send to the meeting, and she spoke, is Teresa Tam, Dr. Teresa Tam, who is our chief medical officer. All of you know her. You've seen her. You see her every day during COVID. And she came and she spoke. And it was the first time we had Canada on an international stage to say Canada supports rare diseases. And she talked about the $1.5 billion that they were putting into it. And she, really emphasized how important it was that we actually are treating patients and getting them access as soon as possible to effective drugs for rare diseases. And I'm going like, yes. We're there on an international stage making the commitment. So for us, it's a huge opportunity. I just need them to figure out what they're going to do with this $1.4 billion, but this is it. But we were really thrilled. And of course, we were also thrilled that at the General Assembly, this is the 4th year they had to reinforce the Declaration on Universal Health Coverage. And again, rare diseases is in there. We had a resolution 2 years ago, a UN resolution on rare diseases, which again is really important. And it says something you all know, and that is rare disease is not just a medical condition. Rare diseases affects a patient's and family's entire being. It affects their socioeconomic being, it affects their ability to work, affects their ability to go to school, it affects their whole, it has some of you will be happy to know that, has a real gender issue, right? Rare diseases disproportionately affects women, not just because women have rare diseases, but because the burden of the care, right, oftentimes falls on the woman. And in many cases, rare diseases does lead to family breakup. And you have many families, which are single parent families, mostly women, who are dealing with rare diseases. And women with rare diseases, like women with many other diseases, are slower to get diagnosed, slower to get access to care. So anyway, what we want to do is be able to leverage all of this, right, into our getting better access to a whole healthcare system, which is something that I want you guys to come to, as many of you as possible. We will host our court conference in Calgary this year. We propose a rare disease network that will be part of the underpinnings for a rare disease drug strategy. You can't do drugs without diagnosis, without proper access to specialists, without proper access to ongoing monitoring and follow-up. This is essential to it. And we proposed it to the government. They actually said, yes, we hear you, that's really important, but we don't want to fund it. The good news is that Alberta Health Fund has actually said we will launch this network. So we're going to be in Calgary in November. We can get some better information on it, certainly get it through Deanna. And we would love to have as many people as possible come to our conference, be able to help support this. We need to make sure that what we're going to drive out is not just access to drugs, but access to diagnosis, access to specialist care, access to obviously the proper patient monitoring, comprehensive care beyond that. So this is our big goal at the end of the day. And as I say, this is what we're working towards. I'll leave you the slides. I won't go through all of them because I think having the network is a really important component of it. But quite frankly, you folks are already involved in many of those kinds of aspects of it. So thank you very much for the opportunity to speak to you. I hope that we get to see you. And certainly we look forward to, don't wait another 4 years to invite me back. Thank you very much.